Myself, Dr. Jibran Ahmed presents to you Simply Pathology, and today we are back with a very important video. Today we are going to discuss about the WHO 5th edition Gastrointestinal Neuroendocrine Neoplasm. So first we are going to discuss in details what are the updates with regards to the 4th edition, and we are also going to see some of the basic features of the gastrointestinal neuroendocrine neoplasm. Then in the next video, we will discuss in details about the gastric neuroendocrine neoplasm. So let us begin today's topic of discussion without wasting any more time. So the neuroendocrine neoplasms, they can arise in most epithelial organs of the body, and they include many varieties with wide differing features. Now the WHO 5th edition published a very uniform classifications for all neuroendocrine neoplasm. So very shortly, there are two types. The neuroendocrine neoplasm can be divided under two headings. One is your neuroendocrine tumor, okay, which by default are regarded as well differentiated tumors or well differentiated neuroendocrine tumors, okay. And we are having neuroendocrine carcinoma, okay, which is regarded as a poorly differentiated tumor, okay. So it is widely divided under two headings: neuroendocrine tumor and neuroendocrine carcinoma. Now remember that previously and now also the neuroendocrine tumors, they are graded into grade 1, grade 2 and grade 3 tumors, okay, whereas by definition all neuroendocrine carcinomas, they are regarded as grade 3. So they are not labeled as such separately, okay, they are by default regarded as grade 3. Now remember, previously in the previous edition of WHO, the grade 3 neuroendocrine tumor was thought to be very close to the neuroendocrine carcinoma. But that is not the case. The grade 3 neuroendocrine tumor is regarded as a well differentiated tumor, okay, and the neuroendocrine carcinomas are poorly differentiated. So there is no relation between the grade 3 and the poorly differentiated neuroendocrine carcinoma. Remember, the grade 3 neuroendocrine tumor is different as compared to the poorly differentiated neuroendocrine carcinoma. So this is the major update that is there in the WHO 5th edition, okay, of GIT neuroendocrine neoplasm. So I will be repeating whatever I have just said right now. The key feature of this new common classification is the distinction between well differentiated neuroendocrine tumor, that is neuroendocrine tumors which in totality is regarded as well differentiated tumor, okay, and the poorly differentiated neuroendocrine carcinoma. So the neuroendocrine carcinomas, they are by default poorly differentiated, and by default all of them are high grade, okay. Always remember, it is only the NETs that is graded into grade 1, 2 and 3. There is no requirement of grading for neuroendocrine carcinoma because by default all of them are grade 3 and high grade tumors, okay. Always remember, the basic change is that previously the grade 3 neuroendocrine tumor and neuroendocrine carcinomas were supposed to be synonymous with each other or similar to each other, but now it has been seen that there is a lot of difference between the grade 3 neuroendocrine tumor and the neuroendocrine carcinoma. So more will be clear in the later half of the video. So stay tuned with me. Okay. So what is it something that is uniting neuroendocrine tumor with neuroendocrine carcinoma, or what is the common feature between them? The common feature is that all NETs and NECs, they share, okay, the expression of neuroendocrine markers, but are now known not to be closely related neoplasm. So although they have lots of differences between each other, but they are united by the fact that both neuroendocrine tumors and carcinomas, they are positive for neuroendocrine markers. Now, the morphological classification of neuroendocrine neoplasm into neuroendocrine tumor and carcinoma is supported by genetic evidence. So, why are we differentiating between two? Because there are some evidence clinically, epidemiologically and histologically as well as prognostically that supports difference between NETs and neuroendocrine carcinoma. How? We will discuss in the later half. Neuroendocrine tumors, they are graded as grade 1, 2, 3 on the basis of proliferative activity as well as assessed by the mitotic count and Ki67 proliferation index. Okay, so now we are going to see the classification of the neuroendocrine neoplasms arising not only in the GIT but also across the hepatopancreatobiliary system. Okay, so this classification applies to not only the GI tract but also the pancreas, liver and the bile tract. Okay. So very importantly, as we see, the neuroendocrine neoplasms broadly, if you see, they are classified under, this is the first group of tumor, that is the neuroendocrine tumor. Then the second group is a neuroendocrine carcinoma, and the third group is mixed neuroendocrine, non-neuroendocrine tumors. Okay, we will discuss about that. So by default, all neuroendocrine tumors, they are regarded as well differentiated tumor. Okay, and they can be divided into grade 1, 2 and 3 tumors, or low grade, intermediate or high grade based on the mitotic count and the Ki67 index. Okay. So in grade 1 tumor, it is less than 2 and Ki67 index is less than 3%. In grade 2 tumor, the mitotic count is between 2 to 20 and the Ki67 index is between 3 to 20%. In grade 3 tumor, it is more than 20 and the Ki67 index is more than 20%. Okay. Now, one very important thing that you have to understand over here is the fact that you have to understand that, for example, over here we are doing the grading in this particular manner. That is all right. Okay. But what is very important that, for example, for one tumor, if you see that the mitotic count is between 2 to 20%, and if you see the Ki67 index is more than 20%, then what you should follow, whether the tumor should be labeled as grade 2 or grade 3. So always remember, in case there is a discrepancy between the mitotic count and the Ki67 index for a particular tumor, then in that case, the parameter having the higher value, for example, in this case, the Ki67 is having a higher value. Okay. So we will take, the higher value into consideration, and then we are going to grade it with the higher grade. Okay. Always remember this particular point. It is clearly stated in the 5th edition of the WHO. Okay, always remember, between the two parameter, it is always seen that the Ki67 index is the one which is giving a higher value. Okay, so this is about the neuroendocrine tumor, which are well differentiated tumors. Okay, which can be divided into low, intermediate, high grade depending on the mitotic count and the Ki67 index. Now the second group is the neuroendocrine carcinoma, and it includes the small cell neuroendocrine and the large cell neuroendocrine carcinoma. So morphologically, they are quite different as compared to the neuroendocrine tumor, and they are regarded as a poorly differentiated tumor because they do not have the classical architectural features of a neuroendocrine tumor. Okay, so that is why, and by default, all of them are regarded as a high grade tumor. And over here, if you see both the mitotic count as well as the Ki67 index, if you see, all of them, they are more than 20, because by definition they are high grade tumor. All of them are high grade tumor. Okay. The third group of tumor is mixed endocrine, neuroendocrine, non-neuroendocrine tumor, which might be well or poorly differentiated, and the grade, mitotic count and the Ki67 index quite varies. Okay, we will discuss about the mixed tumors in the later half of the video, so stay tuned till the end. Okay. So for calculating the mitotic count, it is to be expressed as the number of mitosis per 2 millimeter square, that is equal to 10 high power fields at 40x magnification with an ocular field diameter of 0.5 millimeter. Okay. Okay. So it is expressed as number of mitosis per 2 millimeter square as determined by counting 50 fields of 0.2 millimeter square. Okay, in a total of 10 millimeter square area. Now, the Ki67 proliferation index is determined by counting at least 500 cells in those regions which are having the highest positivity, or they are having the highest labeling, or they are the hotspots. And how do you identify such hotspots? In the lower magnification or at the scanning magnification. So you should remember them, that how you are calculating the mitotic count and the Ki67 index. As I already explained, in an event, if for example a particular tumor is giving two different values for your parameters, like the mitotic count is 2 to 20 for one tumor, whereas the Ki67 is higher than more than 20. So in that case, in the event that two proliferation indicators suggest different grades, the higher grade is assigned always. Okay, and generally if you see, whenever there is discordance, you will see that it is a Ki67 index that is giving a higher value. So that is basically chosen for the higher grade. The neuroendocrine carcinomas are considered high grade by definition. So by definition, they are regarded as a high grade tumor. In earlier classifications of both pancreatic and gastrointestinal neuroendocrine neoplasm, the grade 3 category was considered to be same as the neuroendocrine carcinoma or as the poorly differentiated neuroendocrine tumor. Okay, always remember this point. This was in the 4th edition. Okay, but in the latest edition, this is not accepted. The current classification and grading system is based on the 2017 WHO classification of neoplasms of the neuroendocrine pancreas, which formally introduced the concept that well-differentiated neoplasms could be high-grade as well. And the high-grade well-differentiated neoplasms are not synonymous with the neuroendocrine carcinoma. So remember this point very clearly. Okay, however, after the publication of data related to the pancreatic nets, okay, it became clear that nets of other organs can also have the proliferation in the G3 range, justifying the extension of this pancreatic classification system in the current edition of WHO classification of neuroendocrine neoplasms occurring throughout the GI tract. So initially this concept was seen for pancreas, and it was again seen that this concept, which was earlier applied only to the pancreas, was also observed in neuroendocrine neoplasms in other parts of the body, including the GI tract, and therefore this classification system that we have just read about right now is applied universally across the GI tract. Okay. Now the rationale. Now, as I told you that the grade 3 well differentiated neuroendocrine tumor, okay, and the neuroendocrine carcinomas are not the same. So why have we created such a sharp demarcation between the neuroendocrine tumor and the neuroendocrine carcinoma? Okay, we will see right now what are the causes and what is it. So always remember that although the NETs and neuroendocrine carcinoma, they share neuroendocrine differentiation based on IHC positivity for chromogranin A and synaptophysin, most neuroendocrine tumors are morphologically different or distinct from neuroendocrine carcinomas. And these neuroendocrine carcinomas, they are of two types, small cell and large cell neuroendocrine carcinomas. Okay. So now we are going to see the basic point of difference between the tumors and the carcinoma. So morphologically, remember, all neuroendocrine tumors, if you see, they have an architectural pattern. So they have organoid nests or organoid architecture comprising of nest, cords and ribbons. They have a very uniform nuclear feature and they have coarsely stippled chromatin with minimal amount of necrosis. So morphologically, this is the feature of a neuroendocrine tumor. But if you look at the neuroendocrine carcinoma, they have less nested architectural pattern. So the architectural pattern characterizing the neuroendocrine tumor is lacking in the carcinoma. That is why they are also called poorly differentiated tumors. Okay, they often grow in diffuse sheets. Okay, and they have either tightly packed fusiform nuclei with finely granular chromatin, that is the small cell neuroendocrine tumor, or they will have a more rounded, markedly atypical nucleus, sometimes with a prominent nucleoli, that is the large cell neuroendocrine carcinoma pattern. Okay, necrosis is usually abundantly seen over here. Okay, so in the neuroendocrine carcinoma, there is a small cell variety, okay, and there is a large cell variety. Okay, and they do not have have any special, or they do not have a particular architectural pattern in contrast to the neuroendocrine tumors, and also they have abundant necrosis as compared to neuroendocrine tumors. The second point of difference over here is the presence of both low grade and high grade components within an individual neuroendocrine tumor provides strong evidence that the high grade component remains a well differentiated neoplasm. Always remember, whether the neuroendocrine tumor be grade 1, 2 and 3, all of them are regarded as well differentiated neoplasm. In contrast, the neuroendocrine carcinomas do not commonly arise in association with the neuroendocrine tumors. Always remember, the neuroendocrine carcinoma, they are not arising in association with the neuroendocrine tumor, but instead they are arising from certain precursor lesions that typically give rise to non-neuroendocrine carcinomas of respective organs, such as adenomas in the colorectum or squamous dysplasia in the esophagus. So always remember that these nets or the neuroendocrine tumors, they are not giving rise to the neuroendocrine carcinoma. Rather, they are coming from such precursors like adenomas or squamous dysplasia, which are actually non-neuroendocrine precursors. Okay, these non-neuroendocrine precursors are giving rise to the neuroendocrine carcinoma. This is the further point of differentiation between the neuroendocrine tumors and the NECs. Okay, their point of origin is different. Okay, so basically pathologically, if you see, or embryologically, they are also different. Neuroendocrine carcinomas may also contain non-neuroendocrine carcinoma elements such as an adenocarcinoma or squamous cell carcinoma, and in that case we are calling them as MINEN. So we will discuss more in details about this concept when we discuss the mixed neoplasm. Now genetically, if you see, Frequent mutations in MEN1, DAX, ATRX are entity defining for well-differentiated neuroendocrine tumors, and such mutations they are not found in the poorly differentiated neuroendocrine carcinoma. So another point of difference over here. Neuroendocrine carcinomas, instead, they have mutations in TP53 and RB1. Neuroendocrine carcinomas instead have mutations in TP53 and RB1. Now, a subset of patients, probably patients who in fact had G3 nets, they failed to respond but paradoxically survived longer than others. So, very important thing, what is it? That the common response of neuroendocrine carcinoma to platinum-containing chemotherapy, which is dramatic in case of small cell variety, led to the standard use of these regimens for treatment of neuroendocrine carcinomas of diverse anatomical origin. So neuroendocrine carcinomas, they are having a very good response to chemotherapy, whereas on the other hand, the grade 3 neuroendocrine tumors, they did not have any response to the chemotherapy. Plus, the patients paradoxically they lived longer as compared to the patients of neuroendocrine carcinoma. Then again, clinically also we can see that the grade 3 neuroendocrine tumor are different as compared to neuroendocrine carcinoma. Prognostically, the neuroendocrine tumors are having a much better prognosis compared with the neuroendocrine carcinoma. So one difference between the current WHO classification and the 4th edition classification of tumor of the pancreas concerns assignment of a grade for neuroendocrine carcinomas. So previously all the neuroendocrine carcinomas were graded G3 like high grade NETs, okay? But the current proposal is not to assign a grade to the neuroendocrine carcinomas. They are all high grade by definition. And this is done to avoid confusion about neoplasms within the G3 category. So whenever you are seeing a grade 3 tumor or they are writing something like G3, always understand that they are a high grade NET, okay? But if you come across neuroendocrine carcinoma, it means it is a high grade, okay? So no need to differentiate on that particular front. Now, the recently published proposal for a uniform classification of neuroendocrine neoplasm is now formally adopted in the WHO classification of tumors arising throughout the entire GI tract as well as in the hepatopancreatobiliary organ. So, whatever we are reading now or whatever changes we are reading now is applicable across the entire GI tract as well as in the hepatopancreatobiliary organ. It is important to remember that despite the use of uniform terminology, there are important organ-specific differences among the neuroendocrine neoplasm in terms of hormonal function, clinical presentation, prognosis, morphology, as well as genomics. Okay, now we will discuss about the well-differentiated neuroendocrine tumors. Okay, first. So the neuroendocrine tumors, they are well-differentiated epithelial neoplasm with morphological and immunohistochemical features of neuroendocrine differentiation, most typically showing organoid architecture with a uniform nuclei and the chromatin that is coarsely granular, not finely granular, coarsely granular. So they can be subdivided into grade G1, that is low grade, G2 intermediate grade, and G3 which is high grade. NETs are a broad family of related neoplasm that can arise in any organ in the gastrointestinal tract and the hepatopancreatobiliary system. The former terms include carcinoid tumor. It was used for GI tract for the neuroendocrine tumor. For pancreatic tumor, they use the term islet cell tumor or they use the term pancreatic endocrine neoplasm. Okay, but right now you might use a single umbrella term, that is well differentiated neuroendocrine neoplasm or neuroendocrine tumors. Now, the well-differentiated nature of NET means that the neoplastic cells bear a strong resemblance to non-neoplastic neuroendocrine cells, usually including very strong immunoexpression of general neuroendocrine markers like chromogranin A and synaptophysin, along with variable expression of specific peptide hormones. Now, the morphological features of neuroendocrine tumors are highly varied and they change from organ to organ. Okay, and some organ specific subtypes have characteristic histological patterns. However, in general, okay, they display a characteristic architectural pattern including nest, cords, and ribbons. So we will show you with the help of a diagram. Now, gland formation by a neoplastic cell is very common, especially in the neuroendocrine tumors of ileum and the pancreas, as well as in the subset of appendiceal and duodenal neuroendocrine tumors. Now, the nuclei often contain coarsely clumped chromatin. The nuclei often has a coarsely clumped chromatin, giving rise to classic salt and pepper appearance. but some neuroendocrine tumors, they show more diffusely granular chromatin and others have prominent nucleoli as well. So there are certain generalized features that you will see across all the well differentiated neuroendocrine neoplasm, and sometimes you can see variations which can be attributed to a particular organ. Okay. Now, the cytoplasm may show intense granularity reflecting the abundance of the neurosecretory granules. Most of the neuroendocrine tumors, they have a low proliferation, okay, defined in the 4th edition digestive system tumors by a mitotic count of less than 20 and a Ki67 proliferation index of less than 20%. Now, although the mitotic count is indeed found to be within this range in almost all cases, it is now clear that some neuroendocrine tumors, in particularly those arising in the pancreas, they have a Ki67 proliferation index of more than 20%, and values as high as 70 to 80% have been observed in some cases. Therefore, the Ki67 proliferation index alone cannot be used to conclusively distinguish the neuroendocrine tumors from neuroendocrine carcinoma. So in addition, you have to see the morphological features, you have to see other features like mitosis as well, okay, in conjunction with Ki67, so as to label a particular tumor as neuroendocrine tumor or a carcinoma. Okay. Now, an important clinical distinction among the neuroendocrine tumor relates to their hormonal functionality. So there are neuroendocrine tumors, they can be functioning or they can be non-functioning. Functioning means whenever the amount of hormone or the hormones that are present in a particular neuroendocrine tumor, they are causing or producing certain clinical syndromes. Okay. So functional neuroendocrine tumors are defined as those which are associated with characteristic clinical syndromes related to abnormal production of hormones by the neoplasm. Okay, for example, in a gastronoma, some gastrin hormone is being produced, so that is giving rise to a particular clinical syndrome. They become functional in that case. Okay, clinically, non-functioning neuroendocrine tumors may also produce hormones. So it is not that always if you find some hormone in the body, so always the person will have the clinical syndrome. So it can be that even in presence of the hormone, the particular neuroendocrine tumor is non-functional. Okay, which can be detected in the serum or in the tumor cells using immunohistochemistry, but the hormones do not result in clinical symptoms. This is what we are trying to say. So the neuroendocrine tumors, they can be functioning or non-functioning. That means clinically they might show sign symptoms or they might not show, and usually they are having hormones in their body, so they are positive, but just the presence of hormones does not indicate a clinical symptom. Okay. The nomenclature for functioning neuroendocrine tumor often includes the name of the specific hormone causing the syndrome. For example, in case of an insulinoma, because insulin is released, so insulinoma. Gastrinoma from gastrin producing tumors, glucagonoma, similarly like that. The pancreas gives rise to the greatest variety of functioning neuroendocrine tumor. But if you look at the GI tract, functioning gastrin producing neuroendocrine tumor, that is gastrinomas, they typically occur in the duodenum. And neuroendocrine tumors that cause carcinoid syndrome, they usually arise in the ileum. So these are very important MCQs. Okay, most gastric neuroendocrine tumors, gastric, that is arising in the stomach, they are non-functioning, although the conditions associated with hypergastrinemia, including gastrinomas themselves, can induce neuroendocrine tumors composed of enterochromaffin-like cells in the oxyntic mucosa of the stomach. Okay. Now, the neuroendocrine tumors of the bile ducts, liver and colorectum are usually non-functioning as well. So, remember one thing, that functioning gastrin-producing nets typically occur in the duodenum, and nets causing carcinoid syndrome usually arise in the ileum. So, remember that. And gastric nets, most of them, they are non-functioning only. Okay. Always remember this. Okay. Another characteristic feature of nets is the expression of somatostatin receptors, in particular abundant SSTR2, which can be detected immunohistochemistry by IHC or by using functional radiographical imaging such as octreoscan or PET-CT. Nets are usually not detectable by FDG PET because they are not a very rapidly growing tumor. Now, another distinctive clinical feature of neuroendocrine tumor is their indolent natural history. They are very slow growing tumor. Although all nets are considered to be malignant neoplasm, early stage nets of all anatomical sites have a low risk of metastasis if they are entirely removed. Larger or higher grade nets, they can metastasize and are difficult to treat, but survival for many years is still possible even in the advanced stage. So this is a very characteristic feature of nets, that they are very slow growing neoplasm, and metastasis is not something which is rare with nets. Metastasis is also there with nets. Okay, But always remember that survival for a longer period of time, even with metastasis, is possible with the neuroendocrine tumors. Okay. Certain types of NETs, example pancreatic and duodenal NETs, they occur commonly in patients with a syndrome like multiple endocrine neoplasia type 1 and are associated with frequent somatic mutations in MEN1, whereas other NETs, example ileal and rectal, are not associated with this syndrome or any mutation with MEN1. So certain types of NETs are showing mutations or they are occurring as a part of a syndrome. Now there are also prognostic difference among NETs of the different sites. These distinctive clinical features mean that the surgical and the medical treatment of NETs is highly dependent on the site of origin. Attempts to determine the origin of NETs presenting with distant metastasis can involve both radiographical and pathological techniques. Okay. So if we see over here, okay, if we see that every neuroendocrine tumor, so here we are looking at a gastric neuroendocrine tumor. Okay, it is consisting of, classically you can see there's a pattern. So you are having cords. Okay, you are having nest, you are having cords. Some places you are having sheets. So you are having cords, nest, sheets of neuroendocrine cells, typically having an amphophilic lightish pink cytoplasm, as you can appreciate. And the nucleus, if you see, they are coarsely stippled chromatin. You can appreciate in this diagram mitosis and atypia are scarce over here. Okay, so this is how a neuroendocrine tumor presents histologically. And the high power view, you can again see the uniform nuclear features with a coarsely stippled chromatin and minimal amount of necrosis. Okay, this is a classical feature of a neuroendocrine tumor, and this particular diagram I wanted to show you the classical pseudoalveolar or the nesting pattern, as we can appreciate over here. Okay, again in the high power view, if you examine, they will have uniform nuclear features with coarsely stippled chromatin and minimal amount of necrosis. Now we are going to discuss about the poorly differentiated neuroendocrine carcinoma. So